morning all. Before I begin, a big thank you to Dr. Ajay for giving me this wonderful opportunity. I'll be taking you through the diagnostics. Coming to begin with, it is fundus fluorescein angiography. As we all know, it's detection of your retinal vessels by photographing the retina once you inject fluorescein dye into your peripheral veins. And how does it reach your eye? Once you inject it into the vein, it goes through your heart, internal carotid, ophthalmic artery, and then into your central retinal artery and short posterior. So coming to the role of fluoresceins in diabetic retinopathy, one important thing to remember is that it is not a screening test, so it should not be used in patients with no or minimal diabetic retinopathy. And so where exactly should it be used? We'll go through some clinical examples, and it will be probably much more clearer after that. So this is case 1. You can clearly see that the left eye has got a tractional retinal detachment, and the right fundus shows a neovascularization and the changes because of diabetes. So once you run your angiography, it helps you to classify and confirm that the type of proliferative disease that you have. Here it has got a high-risk PDRs, and it helps you to decide the urgency of your laser treatment. And also, it gives a lot of information about your macula. An important thing to remember is not to ignore the macula when you start doing your PRPs, as you can really worsen the diabetic macular edema. So identify your MAs, identify your areas of non-perfusion, do your grid or anti-VEGF combined when you are dealing with a proliferative diabetic disease. Why is it important to repeat your angiography after you complete your laser? That is to confirm regression. Only 1/3 of the eyes, they show successful regression of NVEs following a standard 3 or 4 sessions of your PRP. So if you notice that after your 3 sessions of PRP, your patient has persistent NVEs, it's important to augment your PRP before you reach a silent-looking retina like that. Another role is to basically differentiate whether you're dealing with a case of a severe or a proliferative disease. Here in the early frames, you can see there are some intraretinal microvascular abnormalities, probably a blocked fluorescence from a hemorrhage. And once you go to the late frames, there is hardly any leakage. So it confirms that this is intraretinal microvascular changes rather than a neovascularization. So there is absolutely no need to start your PRP at this stage. Coming to diabetic macular edema, so there are 3 different situations. Your OCT shows intraretinal fluid in all 3, but your FFA will give you a completely different picture. So this is case 1. He has these leaky microaneurysms, CNP, and this is a non-centered DME. Few MAs which are very close to your fovea. So important thing to know is that focal laser has to be done to your leaking microaneurysms. You can do a little grid to your non-perfusion, but remember not to treat within 500 microns of your central fovea. So these MAs should not be ideally touched. So this is case 2. The patient has received macular laser in the past. So do we really need to do an angiography here also? The answer is probably yes. As once you run your angiography, what you notice is that these are the areas which has been previously treated. And now this is the area of leaking microaneurysms which is causing fluid on your OCT. So FFA is helpful to assess the adequacy of your previous macular laser treatment. Coming to ischemic maculopathy, here your OCT shows intraretinal edema. There are a lot of hard exudates on your OCT, on your color picture. But as soon as you run your angiography, you notice that here you're dealing with an ischemic macula. So does really anything have a role? That's a big question. So take-home message so far is that FFA is important at your baseline to identify ischemia, focal or diffuse leaks. It helps you to plan the treatment, what to treat and what not to treat. And it's also important after the laser to assess the adequacy of your treatment. So moving on to ultra-wide field FFAs. This is a traditional 7-field fluorography, which is going to capture around 75 degrees of your retina. When you do an ultra-wide field, you'll be able to get around 200 degrees. That's going to cover around 82.5% of your retina. So what can be easily missed on the traditional photography can now be picked on your ultra-wide fields. It has been proven so far that the detection of NVE and CNP is increased by around 10% by using these ultra-wide fields. And this is a very normal picture that everybody is used to see. It's of an optical coherence tomography with some morphological assessment of the retina. Coming to its use in diabetics, it's mainly to evaluate any unexplained visual acuity loss. It helps you to monitor your treatment, and it also helps you to identify the areas of VMT. This is a standard OCT classification that all of us must be aware of. So I'll be skipping up these two ones. Coming to the clinical cases. So this is case 1. Color picture doesn't really show much except a leaky, probably a small microaneurysm in the right eye, and he's been a diabetic for the last 12 years. So as soon as you run your OCT, you can pick up these small little cystic pockets, and central foveal thickness is increased to around 300 microns. So OCT is useful to detect early diabetic macular edema. This is another typical patient of proliferative disease with very clear-cut petalloid leakage coming up as a CSME. But as soon as you run your OCT, you figure out that you're dealing with something more than just a CSME. And so this patient also has a VMT. So absolutely no role of antiVEGFs, and he has to undergo a vitrectomy along with or in combination with either an implant, Ozurdex implant, or with an anti-VEGF. This is the post-PPV scan. Now you can carry on with your further management of diabetic edema. So OCT is important to identify your VMT and also to monitor your treatment responses. So the first picture shows a pre-anti-VEGF injection OCT. As soon as you do an anti-VEGF, you can see the serous fluid is disappearing, your intraretinal fluid is settling down, so you are on the right track. Another way to monitor is to look at the automated values, which some people would like to follow. So from 305 microns, you are down to 260, suggesting that OCT helps you to monitor. So this is the last part, which is OCT Angio. It's a non-invasive test. It gives you individual vascular plexus separately. These are the advantages and disadvantages. And so this is a montage. If you run a clear-cut standard fluorescein, you can pick up multiple NVEs. And as soon as you perform an OCT montage using 12 by 12 mm Pixelate, you can very clearly pick up a similar amount of NVEs. So there is, it seems that there's probably a little role of fluorescein left at this moment. Another patient's NVD very clearly seen. Another usefulness is to monitor the response. It's a big front of NVE in the figure A. As soon as you treat, you can follow it up on OCT angio. That clearly shows a lot of regression and a lot of pruning of the particular vessel. Not always useful. I'll be wrapping in the next 1 minute if that's okay, sir. So there are leaky microaneurysms, but your OCT angio doesn't really give a very clear-cut picture, as there's a lot of masking happening because of the hard exudates. So future is bright, and we leave it for the next AIOS talk. Thank you.